Good afternoon to all of you, and welcome to the nursing debates of the 1968 clinical sessions. In our society, debating has become an important means of acquainting the community on issues surrounding significant questions and problems. Certainly, debating is no stranger to other professions, and recently, the political scene has seen a renewal of debating as a means of exploring an opponent's point of view. Nursing, on the other hand, has relegated the value of debate to the floor of the House of Delegates within parliamentary procedure. As a means to greater understanding of policies to be decided, parliamentary debate is most appropriate. Debating, however, can serve other useful purposes. It can stimulate interest, disturb thinking, and explore issues and problems around everyday practice in nursing. And at the same time, its structure is such that the participants in debate are protected and the issues themselves come to the fore. The advisory committee proposes that the time is most appropriate for the profession to give some attention to current problems in nursing at a national meeting. We have made every effort to select carefully from three vital areas of concern to nursing: education, administration, and practice. Unlike parliamentary debate, these panels are not policy making. Issues here will be explored. For example, this afternoon's debate concerns nursing administration. In our present complex society, not everyone knows everything. Specialization is a reality. Systems of behavior which operated before no longer serve a useful purpose. What then is the nature of the position of Director of Nurses? If it is primarily management, it could be done by a non-nurse. If it is primarily nursing leadership, then it should be done by a nurse. It appears then that the director is involved in either practice or administration. Or is it both? The question could be, is the nature of the position in the title? Again, is it really that simple? Talk to boards of trustees or agency administration and you get one concept. Talk to nursing staff and you get another. Therefore, it is our pleasure this afternoon to introduce to you a resolution to be debated by this panel. Be it resolved that directors of nursing services need not be nurses. Our team is an illustrious one, and on my right, Miss Dorothy Wheeler and Miss May Hamilton, and on my left, Mrs. Ann Zurcher and Dr. Luther Christman. It is now my pleasure to introduce for this afternoon's debate, resolved that directors of nursing need not be nurses. And the first affirmative speaker, Miss May Hamilton.
Ms. Large, fellow panelists, and colleagues, as Ms. Large told you, we are supporting, Ms. Wheeler and I, the proposition that a director of nursing service need not be a nurse. We are saying that this individual who has full authority and responsibility for the administration of nursing services need not be a registered professional nurse. Now, this proposal is predicated on two assumptions. The first one, of course, is that the non-nurse has the substantial knowledge and the administrative ability for the position. The second assumption is that the position of the non-nurse fits into the context of appropriate organizational conditions and circumstances. We cannot put a new kind of director into an old kind of structure any more than we can put new wine into old skins. Mead tells us that the most vivid truth of our time, of our age, is that no one will live all of his life in the world in which he was born. Life is learning to adapt to change, and adapt we must. So we offer 3 reasons for adapting to change, 3 reasons for modifying present nursing service patterns to support a non-nurse director of nursing service, who of course can provide professional administrative leadership. The first reason, 2 related and interdependent factors implicit in the director's position itself. First, the broad scope of her functions, and secondly, the managerial nature of her role. First of all, FS&Q defines 2 broad areas of responsibility, one clinical and one managerial. And secondly, as these functions are defined by FS&Q, the managerial role appears dominant. Again, the United States Department of Labor's occupational titles reflects the image of this individual, of this managerial individual, defined by both the hospital administrator and directors of nursing service. Their definition includes such responsibilities as fiscal management, statistical analysis, personnel and labor relations, not to mention promoting good public relations and working relationships with the community, the kinds of functions that require organizational skills and managerial ability. Again, search the literature, which describes the director of nursing service as an assistant administrator with the responsibility for designated tasks in his, the hospital administrator's, absence. However, the hospital administrator's job is changing. He is no longer just the custodian of the plant. The community health center approach has broadened his role to that of policymaker, innovator, program planner, program developer, a broad social role in the community. And as the hospital administrator's role changes, so will the role of the nursing service director. At a time when the health fields are in the center of social and organizational change, we seem to be experiencing some diminishing nurse manpower. So we cite this as a second reason for supporting a non-nurse director. We do know that while enrollments in the master's programs purporting to prepare nurses for administration and supervision have virtually disappeared, that enrollments have increased in those programs which prepare for clinical specialization. In order to utilize to the fullest these graduates, these experts, for the nursing care of patients, we should think about and devise organizational patterns in which non-nurse administrators can function at all levels, not just at ward level. A third reason we offer for changing patterns and consideration of a new role is the trend toward specialization in the health services. Today's hospital is an extremely complex organization of both professional and technical services. As specialization increases, so does the need for coordination and interdisciplinary collaboration. To articulate and constantly coordinate the many diverse but related activities within the hospital is a very important but arduous task, requiring, to quote Dr. Chrisman, substantial knowledge, some innovative ability, and reasonable competence in interpersonal relationships. At this point, no mention of clinical nursing expertise. We suggest, I know that I'm going to pay for that. I have a feeling. I know. But I just couldn't resist. We suggest that two related and interdependent developments in specialization, the clinical specialist and the service manager, are conducive to structural arrangements in nursing services in which a director need not be a nurse. Now, the clinical specialist has been defined in the literature generally as one who assumes responsibility for the quality of nursing care received by patients. The service management system also has received quite a bit of attention by persons, Broad, Chrisman, Houts, Mercandante, and others. The purpose of the service management system, of course, is twofold. One, to relieve the nurse of management responsibilities and to provide administrative control at the front line of the organization. We propose a pattern from which has been eliminated the positions, first, of the Director of Nursing Service as an extension of hospital organization, and secondly, the ambiguous position of the administrative supervisor. We initiate the clinical specialist, a nurse specialist with clear but well-defined authority for improving nursing care. We propose no one pattern. The literature reflects many patterns of the use of the specialist, coordinated teams of specialists, groups of specialists, all of which suggest a structural looseness, interdependency, and a broader base of authority at the top, an authority aware of the sentiments of the specialist and in turn respected by them, but most important of all, it suggests more experimentation within the operational level. We stress experimentation with new patterns and new roles. In summary, we have supported the proposition that directors of nursing service need not be nurses. We offered three arguments. One, those factors implicit in the position itself. Second, an inadequate source of administrative potential in nursing. Third, the trend towards specialization and concomitant problems of integration and coordination. We proposed the study and experimentation of organizational forms attendant upon two areas of specialization, the clinical specialist and the service manager, both of whom relate to a non-nurse professional administrative specialist. Thank you.
Thank you, Ms. Hamilton. The first negative speaker will now present the case for the opposition, Mrs. Ann Zurcher.
Ladies and gentlemen, I speak in opposition to the statement that the Director of Nursing need not be a nurse. I will attempt to defend my position by sharing with you my viewpoints, which you may accept or reject based upon your own image of the Director of Nursing Service. The role of the Director of Nursing, as you well know, has changed over the years. To tear down the statement about adaptability, I would say that as Directors of Nursing, over the years, we have been most adaptable, and perhaps too adaptable, in assuming some of the responsibilities that rightfully belong in the area of management. I would like to defend our position from the standpoint that our prime responsibility is to direct the clinical practice of nursing. And with it encompasses certain factors of management that cannot be separated from the role. However, I will say that there are many areas of management which could fall into the service management area that we have carried over the years and will certainly have to give up as our roles become more burdened with the coordination of patient care. It seems rather strange to me today that we're really debating whether a nurse should be in the role, because over the years that I have been engaged in nursing service, I have found that nurses have had to shout and fight and struggle to get up to the point where we now have a voice, and a loud voice, in directing the quality of care which we expect in this day and age. And now that we have arrived, and I think many of us have, and some have a little way to go yet, that we're beginning to question whether we really belong there. And I do challenge the statement that we do not have a source for adequate leadership in the administrative area or the director's role in nursing practice. Of course, I think the role that you play in management has a lot to do with the size of the institution, the nature of the institution in which you're employed, and your scope of responsibility. It is wise and advisable for us to call upon other areas for help in the managerial role. And I can use the area particularly of finance. I think in the area of clinical practice, we need to determine the kinds and quality of personnel that we will need to provide adequate patient care. But to sit down and figure out the actual financial involvement, we do have resources available to us to assist us in this area. But we must have a voice in the kind and the quality of the personnel which we will direct to give and provide the best patient care. There are two distinct areas which I think where we're in conflict. One is this managerial care, or this service area, and the other one then would be the clinical care, which I feel is the prime responsibility of a registered professional nurse. I do not believe anyone who has not been exposed to the area of nursing can provide the depth and understanding and the judgment required to provide high quality patient care. I do think we need to explore new patterns, and I think that certainly no one is better qualified to explore new patterns in nursing than a professional nurse. I don't think that a non-nurse would have the base of knowledge to do this. I have been privileged over the years to serve in a consultant capacity on several occasions, and I am sure in my own way, with my background in nursing, that I was able to provide a different kind of knowledge that could have been provided by any other person. In fact, I have gotten into some situations where it would have been disastrous if a nurse had not been called in, and this concerns particularly in the area of construction of facilities where we will provide our patient care. I believe that in nursing we have kind of traditionally kind of fought for something and then looked around and wondered why we have it. We have, as nurses, assumed too much responsibility for hospital management, and I think that out of this, assuming this role, we have cheated the area of clinical practice. And I do believe that all of us in nursing service today are taking a second look and redirecting our activities to spend the greater part of our time in this area for which we are prepared. I believe we might have to look at the title. I don't know that we need to call her a Director of Nursing Service. I would like to see the word Director of Clinical Practice or Nursing Practice used. There are certain elements of management which we cannot give up, and because they are part and parcel of nursing practice. The service areas which we might call hotel services that could be available to our patients certainly can be better done by other people who are more qualified in this area. Looking over the years that we have come a long way in nursing service administration, from the time when the nurse or the superintendent, as she was called in those days, was kind of a one-man army of management where the nurses served the food and did all these chores. We have gotten away from this. Some areas, I'm afraid, have not, but I think by and large, these have been taken over by service departments or auxiliary departments, and that we are now gearing ourselves to the clinical practice. I don't believe that the director of nursing service or director of nursing practice can be an expert in all areas of nursing. She must be knowledgeable in all fields of nursing and surround herself with the best qualified clinical specialists in assistant or associate capacities so that we can upgrade the quality of care. I do not believe that a non-nurse should be directing the practice for which we are prepared, and I have a firm belief and a firm commitment to this point. The Director of Nursing Service there are major areas which have been defined in the FS&Q. I would like to just briefly review the ones, and I think if the ones that I have identified as major areas in the Nursing Service Administration. This would be the formulating of objectives for the Department of Nursing based on the hospital's objectives as it relates to the care of patients, education and research, analyzing the factors involved in these objectives, determining the procedures and conditions necessary to carry them out, determining the numbers and kinds of personnel needed, and defining the functions of these personnel, providing for coordination of effort, securing the ways and means, and evaluating the results. Nursing Service Administration planning must be a continuous process based on evaluation of these results. I do not believe that a non-nurse can fulfill these responsibilities as I see them. However, I do recognize that there is a great deal of management involved, and I do urge the directors of nursing service to seek specialists in management to give support to the overall running of the department. We do recognize that the nursing service director usually is responsible for over 50% of the hospital's personnel. She is responsible for over 50% of the hospital's dollars. However, this does not mean that she is responsible for setting up all of the policies as regard to labor relations, all of the economic measures that are involved, and it is not her responsibility to seek the funds. However, it is her responsibility to determine the kinds of funds that she needs and to make compromises that would be imposed by restrictions of budget. I think in major hospitals, we have seen a great number of the managerial chores that have evolved out of nursing service. And I would think particularly in the area of personnel management. There was a time when the nursing department was primarily responsible for its own management of personnel. I think that we have been relieved of this part of the managerial part of employment situations where we have qualified personnel directors who assume this role. And there are many other areas where hospital administration has recognized that we have been carrying and shouldering the burden for management, which really rightfully does not belong in our hands. I would like to sum my defense by saying that we have fought long and hard. I think that we have done a noble job. We have had, unfortunately, a lot of problems, a lot of crises in nursing service, and I think our nurses have done a remarkable job in meeting these. And I think now that we're on top, and now that we have arrived in the responsible position where we have a strong voice in the management of the clinical practice, I would hope that we would not relinquish this to a non-nurse, and that we would fight long and hard to maintain our stature. Thank you.
Thank you, Mrs. Zurcher. The debate panel would like to present the rebuttal speeches. The first speaker in the rebuttal program will be the second affirmative speaker. I would like to present to you Ms. Dorothy Wheeler.
I found myself, in some sense, agreeing with Mrs. Zurcher that we have fought long and hard for mediocrity. The Peter Principle seems to apply in our case. The Peter Principle says thus: in a hierarchy, each employee tends to rise to his level of incompetence. Every post tends to be occupied by an employee incompetent to execute its duties. This principle applies to all levels in the nursing service hierarchy. Competent clinical nurse practitioners become incompetent head nurses. Competent head nurses become incompetent supervisors, and competent supervisors become the most incompetent directors of nursing. In November of 1962, Ms. Zurcher made some comments relative to an article which I had written on nursing service administration, and I quote her: "Hospital administrators have respect for a capable nursing service administrator who completely administrates her department. Further, she must speak with authority as a member of the management team, nothing about her nursing abilities. She must learn to make some compromises in her role." And further, Ms. Zurcher says that the good nursing service administrator will look to other members of her staff for the day-to-day operation of the department. And she must learn to delegate. She must learn to let her subordinates do the work. She must free herself to participate as a member of the management team, and she must prove to administration that she can make a greater contribution to the organization in this management role. Now, my good friend Dr. Christman has been very busy as well, and he has written a number of articles about leadership and our roles. And he says that most nurses in leadership positions attend to the parts rather than to the whole of the organization and its relationship to society. Their experiences have not prepared them for imaginative leadership, but for functioning at the lowest or rule-keeping level. And he further says that the instability of leadership exacts a terrific price from our profession. And nurses show a marked tendency to cope only with the immediate pressures. The traditional role of the nurse in nursing service administration at the graduate level has been fast disappearing. And we are quite proud, and quite properly so, of the numbers of our nurses who are seeking further clinical preparation. The traditional modes of coping with organizational patterns will soon be outmoded. And it is my hope that in this outmoding, that the clinical specialist will be given the opportunity to practice our profession at the highest level of competence, and that she will be free by a management expert fighting her battles, if this must be, and fighting the battles with the kind of interpretation that a clinical specialist, a clinical nurse, can give him in terms of truly ensuring good care to all sick people.
Thank you, Ms. Wheeler. The closing of the debate panel is usually, and in this case today, true, by the second negative speaker. I would like to introduce to you Dr. Luther Chrisman.
Worthy opponents, colleagues. In evaluating what one writes or speaks about, it's very easy to gratuitously lift out of context words and twist them to have a variety of meanings. Meaning is not in words, it's in behavior. It is what we do, not what seems to be a symbolic transmission of an attempt to communicate meaning. And we often get bogged down in the wordiness of it and not in the action that has to be forthcoming from what we do. I would submit that in order to give effective patient care, that there has to be a clinical organization of that care, because clinical practice in its essence means the translation of science, basic science, into a helpful relationship with a patient or a client. In essence, it's an activity that assists in preventing, reversing, or arresting a pathological state in a patient. It would seem almost impossible under these kind of circumstances for a person to direct practice of any group, of any clinical group, who did not have the competency necessary to have this kind of insight. Furthermore, in order to have access to the resources that are necessary to give patient care, expert clinical judgments must be used at every level of that organization, whether it's for physicians or nurses or clinical psychologists or other persons who are clinicians. Clinical judgments, in essence, is the symbolic manipulation of the world around the patient and a mental rehearsing of the conditions under which the patient now finds himself, and an arraying of that information in a scientific, or at least a highly studied classification, so that persons may evaluate the consequences of doing or not doing an act of intervention. And this calls for exquisite skill, and it calls for persons not only at the action level to be conscious of this, but it calls for persons to be at the administrative level of clinical management in order to make sure that the conditions are right and proper for this to occur. And Ms. Hamilton will be probably interested in knowing, since she is talking about models, of at least one model that's attempting to allow the practitioner to function the way the practitioner is prepared to function. That is, to give the authority at the action level where the action is. This model has in its is predicting that, amongst other things, that we have 3 to 4 times the manpower in nursing in this country that we are now using if we use our manpower clinically instead of wasting it through managerial practice. And if it also predicts that, and one of the hypotheses to be tested is that all practical nurses and nurses' aides can be eliminated entirely from the nursing department. When we're talking about organizing practice, we are assuming that the present models of organizing hospitals are the appropriate ones. The scientists with whom I worked at the Institute for Social Research, because I was a member of the section on organizational behavior, are believing that almost all the present bureaucratic models have very little value to serve society. For instance, one model proposed by a sociologist suggests that if we are to deliver effective clinical care to patients, that the whole management staff relationship in hospitals be entirely reversed, that the persons with the major decision-making power in the hospitals should be physicians and nurses, and all other people should be backup people to them and be there to staff the needs of the clinical situation so that the practitioners could move forward unharassed with minutiae. In addition, since I only have 1 minute left, I want to run through three notions very quickly. That do we want to present a posture of dependency to the other professions that we are unable to manage our own destiny and our own affairs? Are we to return to a posture of dependency in our relationships with other disciplines? Because if we have a non-nurse managing the nursing department, when in fact the department heads meet in hospitals or other health agencies to organize care, we will not have a voice, and our own particular ethos and orientation and attitudes towards patient care will be underrepresented in most instances. In addition, a person cannot use the knowledge they do not possess. A person untrained in the clinical process cannot direct it nor enable others to see how new patterns of nursing care can be developed. And as we anticipate the future, with all of the explosion of knowledge and science that's available, there will be many breakthroughs in patient care. But those breakthroughs that are of a highly clinical import can only come from the expert use of all of our clinical knowledge collectively.